Still good morning. I have a big pleasure to co-chair this session with Professor Manuel Pan and Professor Habib Samady. He will come, he will appear. Yeah, okay. We have a distinguished set of panelists: Davorka, Lulic, Niccolò, Ciardetti, Vojko, Kanic, Hyun-Jong and Peter O'Kane. So please take.
Thank you so much. I just want to say that we have a wonderful session, but as Professor Soroy's mentioned, if we can allow him 5 or 6 minutes at the beginning of the program, he's going to just share with us his concepts about hierarchical phase CT contrast. So we do sort of, we're going to try to get all the other speakers in, but we want to have Professor Soroy share some of this really latest concepts with us.
I should not have mentioned it now. Okay, so that's my first slide. You see that clearly this morning we were talking about the photo counting detectors, and beyond the tidal wave, let's have a glimpse into the future with the hierarchical phase contrast tomography. It's called HIP-CT, going from microscopic volume rendering to microscopic morphology. So what you have today is to take note of that paper. The video is in this paper, and as you could see, it's a brand new data, and Rio Torri from the London is working with us. So the statement here is in the future, we could have a resolution of 20 micron per voxel and ultimately a resolution of 2.26 micron per voxel with the hierarchical phase contrast. So the video is going to show you a lady of 87 years old, okay, a stent in the LAD, an inferior myocardial infarction. I will not talk about the mitral, but she has also mitral regurgitation. So if we are ready, let's look at the video. We will start by the volume rendering. Yeah? This is the fat surrounding a heart. We go through, and then notice immediately that you see the artery and the vein. Look that you see the primary, the secondary, the tertiary, the quaternary vessel. And if you look, you can see that all these small vessels, less than 400 micron, is going perpendicular to a myocardium. So it's as if the fat has lifted away the coronary artery from the myocardium. I have never seen that pictures, and it gives us a lot of idea. The black is the place where you have some subendocardiac ischemia of injury. We will not have the time today to talk about the mitral valve and the other. So I just have 4-6 slides. I'll let you see again, going back. The resolution of the aortic valve and the mitral valve is phenomenal. The resolution of the compact myocardium, the border zone, I don't have the time to show you that today, but it's quite fascinating. So this is two hearts. One is 60 years old male, no comorbidities, normal heart, and this is the lady that you just saw a few seconds ago. And what I never realized, for me, that's conceptually something new in my brain, that you could have this coronary artery lift away from the myocardium. And basically, if you calibrate that, you can see that all these small vessels are arterial, basically, 400 micron and even less. So when you think about microcirculation, I always thought it was in the myocardium. But now I realize that the fat surrounding the heart can collapse and compress all these small vessels. And for me, it's a really new concept. Yeah? So this is a conventional virtual CT pullback. The vessel in blue, the fat is in green, that's called perivascular fat. You know the Caristo technology with the Ansfindel unit to say inflamed perivascular fat is Hounsfield Luna even lower than -70. And then if you look at these, at the fat around the heart, it's unbelievable what is there. I make some beginning of the listing, you know, adenopectin, cytokines, gaseous messenger. We know nitroxide. I didn't know about hydrogen sulfide. So it's really amazing. And then could the perivascular fat mechanically interfere with the conductance resistance of the pre-arterial and arterial and the responsibility? So I go quickly. You know these pictures. I don't want to interfere too much. Again, that pictures by multi-slide CT scan versus a cast of polymer, plastic polymer of the anatomopathologist. You can understand why it will be quite funny. Now, look at this. This is the top panel A, and you have the RCA. And the RCA is in panel C. And with this voxel resolution of 2.26, you see the adiposity, you see the lumen, you see the media. And if I zoom in the vessel wall in panel D, then you see small nodule of calcium, you see atheroma, you see media, you see vasa vasorum. The stent with the calcium around, that's a banality now, okay? And this is already the last slide. On the left-hand side, that's the non-invasive hierarchical contrast computed tomography. And on the right-hand side is the work of Gary Turney with intravascular micro-optical coherence tomography, published in Nature already a few years ago. And you could see crystal of cholesterol. You see the cap crystal of cholesterol, and then the necrotic core. And you can even see leukocyte attached to the endothelium. So the question that I was asking myself, if available, what are we going to do with that level of image granularity in the context of revascularization? And that's my final slide, but now I have to say the truth, all the truth, but the truth. Oh, yeah, let me see. So I misled the audience, and I must confess, okay? It's a post-mortem art. It's fixed in formaldehyde. The impinging photon is accelerated linearly by a synchrotron, which is in Grenoble. And as you could see, the heart is in a container, okay? And there is 170 meters between the cyclotron and the heart in the container. But it's a major program of the European Union, which was started at the time of the COVID. They want to understand the microstructures of the lung without cutting through. And this is going to be used by the anatomopathologist. So my last slide, and instead of rotating beam, we have to rotate the heart, okay? So the conclusion, if the future is unrealistic, fortunately, it will remain the future for us. If the future is realistic, sadly enough, it will soon become the past. That's my philosophy in life. Yeah.
Patrick, thank you very much. As usually, you shocked us. It's really difficult to come back to the real program of the session. My feeling is that might be at least this kind of research will make possible to let's say to construct to project new drugs, new strategies of treatment for atherosclerosis, at least. So, but now the realistic plan is session number 9. The topic is how should we treat 001 bifurcation stenosis. This is one of the unmet demands of interventional cardiology. Let's start with the first presentation. comparison of outcomes between 1 and 2 stent technique for Medina 001 coronary bifurcation lesions. Chang-Wook Nam.
Thank you, Chairman. It's my honor to have a presentation in here. And then sorry about bringing you to the floor again. It's realistic. Yeah. So there is a limited evidence regarding the optimal treatment strategy for the Medina 001 bifurcation lesion because there is some uniqueness and the rarity of 001 is lesser than 5% in reality. So today I will a brief introduction about the 001 lesion. So first thing is how many 001 lesions in our daily practice. So to solve this, the answer, so we need large registry data to the prevalence of 001 lesions. So we make an extended bifurcated registry, including COVID 2, 3, and RAIN registry, more than 8,000 of patients performing bifurcation PCI, and do the Medina classification, and it was 4.1% for 001 lesion. It's really rare. And the second question is their behavior of a 001 bifurcation lesion. Is it benign or malignancy? So according to the previous COVID-2 trial, we find out that the true bifurcation lesion is more event rate compared to non-true bifurcation lesion. And 001 is non-true bifurcation lesion. So in this extended bifurcated registry, we find out true bifurcation lesion is higher event rate than the non-true bifurcation lesion. But if you see the 001 lesion, even though it's anatomically non-true bifurcation lesion, but the event rate is most high numerically. But as you can see, the COVID-2 registry is more than 15 years ago, so very old style. So we exclude again about COVID-2 and include ultra registry performed in Italian group and very recent data, and then gather more than 6,000 patients and then do analysis, same thing. So how about the Medina class 001? Same instance, 4.0%. And how about the behavior? Same, even though it's a recent trial, but recent data, but it's still very high event rate. So I think it's 001 behavior is a little bit malignant, not the benign. And again, back to the extended bifurcated registry. So we compared the one stent and two stent strategy. So when it was more than 15 years ago, we preferred the two stent strategy. At that time, we focused on the technique. Maybe you can remember that. So I was a junior, but you are very know about that time trend. It's a complex procedure. But recently, getting provisional approach more. So mostly one stent technique was performed recently. How about the result compare the one stent strategy and the two stent strategy? So most of a two stent strategy location is a left main or LAD, more than 95%. But the one stent strategy, non-left main bifurcation is higher prevalence. And so how about the technique? The kissing balloon technique was performed mostly in the two stent strategy, but the pot technique is preferred in the higher prevalence in one stent strategy. And about the QCA data, it's very limited data because COBI's data is a QCA, but the RAIN registry do not have a QCA data, so it's a very selected patient. But anyway, two stent strategy has a relatively small side branch reference diameter compared to one stent strategy. So it means it's a side branch is a bigger, we can approach the one stent strategy. And about even though it's a 001, it means that there is no main vessel disease, but diameter stenosis is two stent strategy is 40%, more than 40%. It means even though 001, but we can assuming that there is some disease in main vessel, even though we classified in the 001. Anyway, the result is primary endpoint was a composite endpoint of all death, MI, and TVR and stent thrombosis. And when you compared one stent and two stent, there was no difference in the outcome. Not only one stent on two stent strategy, but also one stent is simple crossover without main vessel opening was same result compared to one stent with strut opening. So there is no difference. Anyway, it's very higher event rate compared to the not the 001 lesion. And when you do the sub-analysis compared to AZ, gender, diabetes, and left main bifurcation and non-left main bifurcation, and the complex 001 and non-complex 001, there is no difference. And the COBIS 2, 3, and RAIN registry also same, no difference. So why there is a higher event rate compared to non-001 lesion? There's a higher event rate in 001 bifurcation lesion because 001 side branch disease is a negative remodeling. So it is higher chance of recoiling and less acute gain. And also, when you treat the side branch with a balloon OR stenting, there is higher chance of injury to main vessel. And also, the side branch has a smaller vessel diameter, and then we will input the smaller stent and higher risk of stent failure. And most important thing is angiographic 001 bifurcation lesion is not always true 001 lesion. Let's simply this case. It's angiographic definitely 001 lesion, such OCR disease. But if you see the IVUS, the distal left main has a more than moderate plaque calcified lesion. So in IVUS, we can say that 101 or 111 lesion, even in main vessel, LAD also have a moderate plaque. So angiographic 001 is not always a real 001 lesion. And when you talk about the treatment option, there is 3 ways of medical approach, or balloon angioplasty and stent strategy. I already mentioned the stent strategy, about 1 stent or 2 stent, is higher event rate and no difference. But I want to emphasize about medical treatment because we already know that side branch myocardial burden more than 10% is a lesser chance. So generally, we can approach with medical therapy. And then we know that the DCB is another good option. But still, there is some strong point and weak point. Most important weak point is we don't have a large clinical data about the DCB use in 001 lesion. So we have to wait the result. So finally, this is my last slide. The incidence of angiographic 001 bifurcation lesion is rare, less than 5%. And recently, there has been a tendency to prepare the 1 stent provisional strategy for treatment of 001 lesion. And an angiographic 001 bifurcation lesion is not always real 001 lesion. So additional intracoronary evaluation like intravascular imaging or physiology would be useful. And the clinical outcome after PCI in 001 appears unfavorable about the stent 1 stent or 2 stent. So therefore, we have to take a higher risk than our thought and consider various treatment modalities when deciding on the most appropriate approach for each 001 bifurcation lesion. Thank you very much for your kind attention.
Thank you very much for this very fair presentation of the real field of 001 bifurcation treatment. Do we have any questions to the speaker?
Okay. Do you think the highest event rate of 001 bifurcation related to the concealed or undertreated the lesion in the main vessel, right?
Actually, we don't have a more advanced analysis about major event cases, but we believe that the early phase of COBIS-2 study is more aggressive approach is a problem. So higher rate of 2 stent strategies, such kind of 001 is make higher event rate, I believe. So more conservative approach will be better. And then also, the second point is even though we believe that that's angiographic 001 lesion, but the reality is not the 001 lesion. Reality is more complex, like true bifurcation lesion, even though angiographic 001.
Do you recommend the more use of intravascular imaging?
Sure. Yes, actually, if you want to treat with stent in 001 lesion, I think we have to use the intravascular imaging before the procedure strategy decision making.
You know the percentage of patients in which physiology was used? Because sometimes 001 is 000. So,
yes, of course, yes. That's why I emphasize medical therapy will be enough in most cases.
You know the percentage?
Sure.
You use physiology frequently in this study or not?
Although this is only retrospective registry data and performing with stenting cases. So it's very limited.
I was just thinking about the presentation that Carlos Collet did and the idea of, bringing anatomy, physiology, all of this together with CT, and it would potentially completely revamp the way we think about all this. But that was really an excellent presentation. Any other questions for Dr. Nams? Okay, so in the interest of time, let's move on. So our next presentation is by Dr. Yoshinobu Murasato, Impact of Medina Classification on Image-Guided Bifurcation PCI. Welcome.
Thank you, Chairperson. My topic is the impact of the Medina classification on imaging-guided bifurcation PCI. 2 years ago, the impact of Medina classification on bifurcation PCI was investigated in the large clinical trial Archmaster, which contains more than 4,000 coronary bifurcation regions. It revealed worse clinical outcome in Medina 001 as in 111 region. Higher target region failure and cardiac death was reported. In the previous speaker, Dr. Nam demonstrated the bifurcated trial, which is the integrated analysis of CORBIS 2 and 3 from Korea and the Rhine registry from Italy. It included more than 8,000 bifurcation cases. And it is similar trend. 001 region has a worse clinical outcome compared to other non-true bifurcation region. So we conducted the integrated analysis of the Japanese bifurcation studies, which conducted complete imaging guidance. We enrolled 4 studies: J-reverse with IBAS guidance, 3D OCT registry with OCT guidance, proper trial with OCT guidance, glider registry with IBAS or OCT guidance. A total of 778 coronary bifurcation region cases included, and the IBAS and the OCT frequencies are almost half and half. Major adverse cardiac event at 1 year follow-up demonstrated that there were no significant difference between the true bifurcation region and the non-true bifurcation region, except for the higher event of the 001 region, 18%. So we compared the risk of the Medina subclass hazard ratio compared to the Medina 010, which is the least event rate. Only 001 region has a higher mass rate with a hazard ratio of 4.1. So we compared these 3 trials. In terms of distribution Medina classification, as the previous speaker, Dr. Nam said, the 001 frequency is almost same, 2.8 to 4.1. So not so frequent population. However, true bifurcation region frequency, Archmaster and bifurcated trial are almost half of the cases. However, this trial, intracoronary imaging guidance is not so frequent, 12% and 49% respectively. In Japanese registry, with 100% imaging guidance, a frequency of true bifurcation region is less, 36%, because of the accurate assessment of side branch region. In terms of PCI procedure, 2-stent performance, the Japanese registry has least percentage, 20%. However, there is a similar trend as the Archmaster. True bifurcation region has significantly higher 2-stent performance compared to the non-true bifurcation region. However, 001 region has more frequent two stent compared to the other non-true bifurcation region. Japanese registry 9% versus 3% in the non-other non-true bifurcation region. E-Arch Master 12% versus 5%. Only bifurcate trial performed the two stent 39%. And the final cavity or strut opening in Japanese registry, the 001 region, more frequent performance was found, 86%. That is similar as in the true bifurcation region, and that is more than other non-true bifurcation region. Even in the bifurcate trial, 2/3 of the cases performed in Korea. However, 001 region final cavity performed 81%. And in terms of pot, in the Japanese registry, demonstrated less pot performance, 32%, compared to the other Medina subclass, around 50%. Similar trend was found in the E-Arch muscle. 001 region, 15%, versus other region, 30 to 40%. Therefore, more frequent two stent and the final cavity and less pot performed in the 001 region. This is a comparison in the major adverse cardiac event in Medina subclass. E-Arch Master clearly demonstrated the significant higher event in the 111 region. A bifurcate trial, there was no significant difference among the Medina subclass. Japanese registry has a similar trend, except for the 001 region. 001 region has a only significant higher event rate. This is a target region revascularization in Medina subclass. E-Arch Master demonstrates a higher event rate in the 111 region and the 001 region. However, Japanese registry, there was no significant difference between the true bifurcation region and the non-true bifurcation region, except the higher event rate in the 001 region. Therefore, imaging guidance improved clinical outcome in true coronary bifurcation region, similar as in non-true bifurcation region, because accurate assessment of side branch lumen expansion and dissection, and appropriate pretreatment according to plaque morphology and distribution, and optimal device size selection, and less two stent deployment. However, worse clinical outcome in 001 region under the imaging guidance was reported in a study because angiographic non-significant members region includes moderate flag and similar PCI treatment as in true bifurcation region, more two stent and final cavity and less spots than in other non-true bifurcation region. These are a possible mechanism of worse outcome in 001 region. Over-treatment of invariable or non-ischemic side branch without confirmation of functional ischemia or peripheral perfusion territory, and more wide bifurcation angle between proximal member cell and the side branch, it leads to the more likelihood of radiological disturbance in the side branch, and hinge motion in the bifurcation, and angiographically non-significant member cell with moderate flag is ignored or injured during a treatment with POVA. Therefore, the following treatment is recommended in the 001 region: prevent side branch over-treatment, decrease the stent number, and care the member cell plaque injury. In conclusion, intracoronary imaging contributed to reduce MACE in true coronary bifurcation region as in non-true coronary bifurcation region, except for 001 region. Despite of the less frequent needs of the treatment of 3 to 4%, 001 region remained higher risk of TLR even under the imaging guidance. Thank you for your attention.
Thank you. Any question from the...
May I ask you, do you believe that that in every single case the analysis of intravascular visualization is right by the operator? Because I guess that this is also the part of weakness arranged by the operator. Because it's not a matter of fact to make a investigation, intravascular IVUS or OCT. The main problem is just a good interpretation and translating these images into the good practical maneuvers.
Yes, totally agree. The intercoronary imaging interpretation is very important, especially the one region. The one region only is very rare. According to the imaging study, the consecutive plaque is existed in the proximal member cell. So the plaque level in the proximal member cell is that problematic. So our study, 90% of the case, provisional stenting proximal member cell to side branch. However, in that procedure has a significant higher TR rate. So that is a feature of the one region.
Fantastic presentation. Thank you very much. Do you think now then we're ready? I mean, given the results of stenting in 001, do you think we're ready for a study now where we don't stent and perhaps we should do this trial of a DCB approach versus stent, because it's quite a high outcome, isn't it? You could drive a trial quite nicely.
According to this study is a historical study. So we learned about the provisional stenting for the one region is not so a good option. So the debarking the plaque in the side branch and DCB is another treatment for the one region. Even in the small vessel, the squatting of the side branch ostium and the DCB is another option. So stent-less, stent-free for the one region is applicable treatment for this region.
Okay. 2 years ago, we published a BIF-R consensus with Patrick. In the paper, you can see the ranking of severity of bifurcation lesion. 001 was the less severe bifurcation lesion. But in contrast, we have the worst result as compared with other Medina classifications. I don't know if we have to rewrite the paper or what is your opinion about this paradoxical finding. Is a bad treatment for the operator? Is a worse type of lesion? What is your...
So the one region should be discriminated for the other non-true bifurcation region, true bifurcation region, non-true bifurcation region, and the other one region. 3 parts should be discriminated.
In the meantime, I have a comment, Professor Murasato. So before discarding the value of drug-eluting stent in in Medina 001, don't you think that we should check if the technique for implantation was appropriate? I mean, POT done not systematically. How it is possible to implant stent in Medina 001 not performing POT when we know that it is really the condition where there will be the measure mismatch between the two sizes? Did you analyze in this direction?
So in the study and E-arch muscle, the one region has less port performance. That is another reason for the worse clinical outcome in the one region. So the one region also has a proximal member cell has a moderate plaque. Should be done. Port should be done for the one region equally as a true bifurcation region.
Okay, well, so I think there are a lot of, would you mind if we just keep moving, because we're a little bit behind on the schedule, and we'll grab you on the next one. Okay, so our next, thank you so much, Dr. Murasato. Let's give him a hand for that. Fantastic. So our next speaker is Dr. Francesca Sanguineti. And it looks like it's going to be a virtual talk, and the title is Decoding Medina 001 Bifurcation, Are all codes equal? Insights from a multi-center registry. Welcome virtually.
Dear Chairman, dear colleagues, thanks for inviting me to present at EBC 2024. The title of my presentation is Decoding Medina 001. Are all code equal? These are results from a multicentric study. Why this registry? Because among all bifurcation lesions, Medina 001 are the less frequent, mostly excluded from bifurcation studies, the most underrated, because probably we consider that this kind of bifurcation is associated to a limited myocardium supply, but they are also those with the worst outcomes. There is at this time no registry dedicated for this kind of bifurcation. So the idea to build an international and multicentric registry, patients were included from retrospectively and from 2017 to 2022. The objective were to provide a real-world clinical, angiographic, procedural, and follow-up data, and to assess the clinical outcome after different PCI strategies, to identify potential predictor factors for the adverse outcome after PCI in Medina 001. Our inclusion criteria was at least one de novo significant Medina 001 lesion that was starting at less than 3 millimeters from the ostium. We excluded all previous PCI in the main or the side branch, thrombotic ostial lesion with the landing zone more than 3 millimeters after predilatation, and we excluded all side branch diameter inferior to 2 millimeters. We collected data, angiographic and demographic and clinical, and we performed clinical follow-up to all the patients included. Our primary endpoint was 3 years MACE, a composite of cardiovascular death, myocardial infarction, and target vessel revascularization. Our secondary endpoint was the target lesion revascularization. We were also interested to subgroup analysis, and in particular to the PCI strategy and comparing ostial versus provisional stenting. We were interested to EBC recommendation applications, considering as application a procedure in which we had the inverted provisional stenting as a preferred technique, with both branches wired, the jailed wire technique, and a pot correctly done. We also compare left main versus no left main bifurcations. So if we look at the baseline characteristic, we can see finally our database counting 273 patients. Female were less represented, and we could appreciate 30% of diabetic patients. The clinical presentation was more represented by stable angina and silent ischemia. Looking at the lesion characteristic was particularly less represented at the right coronary artery, and the side branch diameter was quite big. For the procedural characteristic, we could see one stent strategy preferred in mostly of patients, but in half of them, we could appreciate an ostial stenting, which is not considered a real bifurcation technique. The use of DCB, as well as the imaging, was less represented. So the endpoint was experienced by 74% of patients at the median follow-up of 3 years, and the only independent predictor of MACE at 3 years was the diabetes. Looking deeper in the technical aspect may be more interesting for this kind of treatment. The 3 years MACE were compared for ostial stenting and inverted provisional. In this comparison, we could not appreciate differences in MACE at 3 years, but we could also appreciate that ostial stenting is preferred when there is an acute presentation, when the bifurcation doesn't involve the left main, and when the side branch is smaller. This probably means that when we are in an acute setting, we probably prefer to go faster and to stay simpler, especially if the bifurcation is not very big. Comparing the EBC adherence, we didn't find differences in MACE at 3 years, but in this case, we could appreciate that the EBC was very well applied and respected when the bifurcation involved the left main, and of course when the clinical presentation was chronic. And going to consideration of the left main involvement, we could see that this kind of bifurcation is associated to more events at 3 years, but we are talking about more stable presentation and a larger main and side branch diameters. Our study, unfortunately, presents a lot of limitations. We are talking about a retrospective design. So, of course, we have some potential selection and bias regarding the side branch dimension in particular. We have not a lot of right coronary arteries included. Our diameters are bigger. So probably there are a lot of bifurcation treated by just oral medical treatment, which was not included in this database. The sample size is unfortunately relatively small. Even if we have 300 patients, we do not probably have enough statistical power, especially in subgroup analysis. And there is a low use of intracoronary imaging, probably because we consider this kind of bifurcation less important than other, and so we keep this kind of expensive technology for other kind of bifurcations. Also, DCB were underrepresented, and this, I think, it will be an important idea for future studies in this particular setting. So in conclusion, this kind of bifurcation presents high rates of the adverse event after PCI. There is an heterogeneity in treatment strategy more than for other bifurcation, but it seems that there is no clinical impact of this stenting strategy on MACE. There is a less common application of EBC recommendation when the artery and the bifurcation, and in particular the side branch, is smaller and in acute setting. Thank you for your attention.
Okay, thank you for your nice presentation. Any comment for the panel or from the audience?
Yeah, I think it's clearly coming out from this study that left main is making a difference. That means when we have distal left main, means we do not have side branch, we have main vessel. In non-left main, I think what is lacking is the medical therapy, the outcome with medical therapy against interventions.
Great. I think there was another comment from the prior speaker, please.
Now, I would be interested in knowing, you spoke about the adverse events occurring. What were the adverse events? Was they related to the side branch or were they related to the main branch problems coming up?
I don't know if you can hear me, but yeah, all our MACEs were principally driven by the target vessel revascularization, and target lesion revascularization was quite high. So I think that the treatment of the bifurcation is what is driving the MACEs at 3 years.
I have the question regarding the ostial treatment of, let's say, ostial stenting of the 001 bifurcation, because it's not well or very loudly disputable thing. We theoretically we should avoid these ostial lesions, especially without imaging before the procedure. Could you tell us really that the results were the same? So it's safe. That was really 001 bifurcations without this imaging. It's safe to do this, let's say, this technique.
I just want to be a comment for, first of all, I really not agreed with this kind of treatment, but of course we have to discuss all the bifurcation included. So even if I not agree with this technique, we can find it in this treatment. And even if we are talking about the 3 big volume center in which I think the bifurcation is very well studied, this kind of practice is anyway founded. I think that bifurcation were really 001 bifurcation, but of course, it was in the limitation of the study. We do not use a lot of imaging, so it's a limit, of course. So I'm talking about angiographic evaluation. And I think that the results, of course, seems to be the same, but we have to consider that this kind of bifurcation, the kind of bifurcation treated with ostial stenting is a bifurcation which is not a major bifurcation. We are talking of a smaller diameter of the side branch. If we keep the mean diameter in our series at 2.7, it's quite bigger, and that's because we are including left vein treatment. So when we are talking about diagonal in particular or marginal branches, of course we are dealing with a smaller diameter. So I think that clinically we do not appreciate event because the ostial stenting is chosen when the bifurcation is smaller, but probably if we could perform a coronary evaluation in this patient, we will probably find more events. But as the evaluation was only clinical, maybe this the myocardium associated with a small marginal or a small diagonal branch is less than for a bigger bifurcation. So that's why it doesn't speak clinically.
Peter O'Kane, just a great talk. I mean, I think the lack of physiology for me is something which I think, is, for me, it's very important to understand whether this is a relevant bifurcation before we start, because clearly I think you've demonstrated, as is the previous talks, that the event rates are higher, and we need to really make sure that we should be treating this before we even embark on it.
All the patients included in the basis, in this phase, had a clinical relevance of these branches, and this was demonstrated by the clinical setting in acute coronary syndromes or by MRI evaluation or CT scan and a clinical assessment or echo stress that was pointing in this territory. So we had actually clinical evidence of the relevance of this kind of bifurcation.
Okay, thank you for the presentation and for your answers. It's time to continue with the next presentation. It's the treatment of 001 left main bifurcation lesion by Soledad Ojeda.
Hello, good afternoon. Thank you very much for the invitation. My disclosure. As everybody knows, 001 left main bifurcation lesions are particularly challenging for PCI. Although different techniques can be performed, such as nailing the osteoinverted provisional stenting, angioplasty with drug-eluting balloons, or even more sophisticated techniques, it's important to highlight currently there are not randomized studies or robust evidence comparing different techniques. There are several key points to keep in mind when dealing with this type of bifurcations. Bifurcation angle is very important. It's important to assess the type of angle. It's important to assess the circ size and the dominance. Other point to consider is the intracoronary imaging techniques, because IBUS and OCT can reclassify the lesions. Really, as previously commented, pure 001 lesions is very, very infrequent. Physiology can also play a significant role in avoiding treating no significant lesions in this complex scenario. Regarding the techniques, the first one, nailing the ostium, although in the past probably was the most popular technique, currently its use is more controversial. However, it can be an option in these situations if the angle is perfect, close to 90 degrees between left main and circ. There is a perfect visualization of the takeoff of the circ, and the left main is healthy. This technique obviously has some drawbacks. There is a risk of carina shifting. Stent protrusion into left main and LAD is frequent, or incomplete cover of the circum or the circle lesion, because a perfect angle, a precise deployment really is not easy. This is a demonstrative example. The patient is a young man with an acute occlusion of the circ after predilation. We can see the lesion, the left main and LAD apparently healthy. So in this context, with the patient in a bad very clinical condition, the decision was to implant an stent, doing a nailing the ostium. But the deployment wasn't easy due to the movement of the heart. But after implantation, really the result was angiographically pretty good. But as we can appreciate in the stent boost technique, the adjustment is not so precise. We assess the result by IBUS, and we can see in the slides there is a pullback from LAD, another pullback from circ, and the stent protruded into the LAD. So it really is difficult to do a perfect nail in the ostium. Inverted provisional stenting is maybe the better option for most of the cases, because the plaque usually extended stents to the left main. With this technique, the ostium is completely covered, and current stent can accommodate significant discrepancy between circ and left main diameter. So the issue of the mismatch is less relevant nowadays. Obviously, the technique also has some drawbacks. There is a risk of damage of the LAD, and if the angle is very wide, the excessive angulation on the stent can be associated with a risk of stent failure at follow-up. This is a demonstrative example video. We can see the video. Video, please, both. This patient had a very severe lesion, a very calcified lesion, and the circ and the ostium. As we can see, the circ was dominant in the assessment by IBUS. We can see the ostial circ with a very severe lesion, a very calcified. So after plaque preparation, An inverted provisional was performed, kissing balloon inflation, and this is the final result, very good. In the stem book, we can appreciate the scaffolding of the LED, and we achieved very good areas in the distal left main, in ostial of the circ, and LED. So in this patient, inverted provisional was a very good strategy due to the anatomy and the dominance of the circ. Drug-eluting balloons can have or can be a potential alternative to this in this setting. It's very attractive technology, yeah, and it avoids the issue of ostial miss or main vessel protrusion. With this technique, there is a lack of data to support this strategy, but there is a risk of optimal result and acute occlusion. So, although the technique is very attractive, we need more data to support the strategy. This is a very representative example. Please, video. We can see video, please. I don't know why. No. This patient was an elderly patient with severe aortic stenosis scheduled for TAVI. The patient had a very calcified lesion at the circ, at the ostium of the circ. We tried to pass the IVUS, but the catheter didn't pass. So we performed plaque preparation with OPM balloon and lithoplasty. After that, the decision was to, considering the clinical characteristic of the patient, the decision was to do an angioplasty with drug-eluting balloons. And here we can see the ostium of the circ, the area very good, considering the critical stenosis at the beginning of the procedure. So in this patient, it was a good alternative. Finally, medical treatment can be an option in some patients when the vessel is very small, the lesion is not a culprit lesion, or the lesion is not significant from a physiological point of view. For example, in this patient, he has an unstable patient with a very severe lesion in the middle part of the circ, and not really a lesion, but yes, a very ambiguous image in the ostium. So our decision was to treat the severe lesion, and after that, the ostium was evaluated by IFR. IFR was negative, so we decided to treat the patient medically. So avoiding a more complex treatment in this scenario. So in conclusion, really, left main is different to the rest of bifurcations. 001 are complex lesions in this scenario. There are different strategies depending on several factors, and we need more evidence to establish the best strategy for our patients. Thank you very much for your attention.
Well, that was an excellent presentation. Thank you. And in many ways, it brings all the prior presentations to life because it demonstrates sort of the contemporary approach using physiology and imaging, and also really focused on the medical therapy component. Any questions from the audience or from the panelists?
Thank you. Great presentation. What do you think is the best strategy in case of nodular calcium in the left circumflex ostium, especially in case of wire bias opposite to the nodule?
It depends, in my opinion, it depends on the severity of the lesion, because lithoplasty, lithotripsy is very useful, but the problem is to the crossability. So in this case, for example, we needed to pre-dilate with OPM and no-compliant balloons, and after that to pass the lithoplasty. Rotablation is an option if you have a good contact of the wire with the nodule, and I don't know if orbital atherectomy will be an option, because we don't have at this moment experience with this technique.
in the last PCR, nailing the osteo was not recommended in the session of Goran. Also, you participate. Do you think that there is a role, still a role, to do this technique, to nailing the ostium at the circumflex? And do you think that it's different, the ostium of the LAD and the circumflex for this technique?
I think in some selected patients, nailing the ostium can have a role. For example, when the circumflex, when the angle is perfect, the circumflex is not very big or very large. You need to implant at least 3.5 millimeter to make sure in the left main you are going to achieve a good apposition. If the left main is very big and the circumflex is not more than 2.75, and the angle is perfect, probably yes. With respect to the second question, there are few data comparing LAD and CERC, but it seems to be CERC has worse outcomes at follow-up. There is we have a study, floating stent in osteal LAD. In this study, the results were relatively good, but comparing CERC and LAD, there is a recent paper with a very small number of patients, no more than 47, and most of them treated with nailing the ostium, and the MACE, the target lesion revascularization at the CERC was higher than in LAD. So it seems to be CERC is the weak point of the bifurcation.
So thank you very much. We have to proceed with the next presentation. Thank you very much. We have still to do. The next one is 001 bifurcation lesions. Does image change our therapeutic strategy? José Torre Hernandez.
Hello, panel chairman. I have to answer this question. Does it may change our therapeutic strategy? I hope in the next slides I could be able to do it. These are conflicts. This is 001. By the way, we are very close to the 20 years of the Medina classification. Next year is the 20 years of this, and this has been extremely helpful. There is no talk that this Medina classification is not mentioned in these meetings. No? This is less frequent. We have seen this, but to start, I will say that it's clearly debatable how well is indicated PCI in these cases. I think side branch, the 001 could be seen now like a wolf disguised of a woolly sheep, because we have seen that it's quite simple, or looks like a quite simple lesion, but the MACE rate is the highest compared to the others. Then I think that should be careful. First, it's indicated to do PCI in these cases. We know that very, very few side branches supply more than 10% of the myocardium. Then how important is the side branch, how symptomatic, medical therapy was optimized or not, is the cause of the symptoms, and finally the functional assessment. Then after this is properly answered, we can establish the indication. What about this lesion is very clear. It's an infrequent type, we know very well. Intravascular imaging assessment, I think, is very important to reclassify the anatomy, and we must not sacrifice or damage the vein vessel, which is the principle of these interventions. The value of imaging is to select the most appropriate strategy according to the anatomy and disease pattern, the size in the devices, and of course, to guide the procedure, evaluate the optimization, and eventually to change the strategy along the procedure because there is some plaque sheath of dissection, whatever. We have different strategies, as Soledad has been shown in the previous slides. Stenting of the nailing the stent, just crossover the stent, or inverted provisional, and the use of DCBs also in different ways. We have two elements that are important for the strategy, which is the distribution of the plaque of the disease in the main vessel and the angulation. This is the angiography. The angiography of these lesions looks the same always, but it's a clear 001, but may correspond to different anatomies, may different disease patterns. All of them look the same because the positive remodeling makes not reveal the presence of the plaque. We have moderate plaque in the main vessel, and the positive remodeling preserves the lumen. So angiographically looks the same, but the disease pattern is quite different. By intravascular imaging, we can identify this pattern and to find where is the plaque, if this is only in the ostium or this is extending to the main vessel in a more or less proportion. These are the bifurcations that are angulated. The angle is narrow, and we can have this distribution. And if imaging guided, maybe we can get this. The problem is that many times, and it's not infrequent, the stent, when we try to nail the ostium, is going to miss plaque in the ostium, or sometimes it's going to protrude a lot within the main vessel. This is a problem that we cannot identify properly only with angiography, and we need imaging just to identify these pitfalls. We have this ideal angulation for these strategies, but other angulations that are not so good. And in fact, we can also predict the combined length or missing protrusion, just considering the size of the side branch and the angulation. In this case, we have the missing 1.7 millimeters, or we have the same length in protrusion. In this chart, in this publication, you can see the different combined missing and protrusion lengths according to the side branch size and the angulation. And this is over 1 millimeter once the angulation is over less than 60 degrees. If we guide the procedure by angiography in a case like this with some plaque extended to the main vessel, then we can have this problem. We can have some plaque shift and even dissection in the entry of the stent. If we do maybe a crossover stenting, but we do not cover properly proximally, we cannot select the proximal landing site, we can get finally this result. This is a good thing that we can get if we use imaging in these cases. For those cases that are perpendicular, things appear like simple, but it's not so simple. Angio-guided, maybe we have this, and we have more plaque that is shift to the main vessel, or we can have the same problem. The proximal landing site in the main vessel, when we are using the inverted provisional, is not adequate. And the best result is obtained when you have a proper selection of the length of the proximal landing site. And this is also a good result with a perpendicular angulation with imaging guidance. It's an example of a subtotal diagonal, typical 001, in this case a patient with a non-steal elevation MI. We did IBUS, we always do the imaging in the main vessel. You see the wire coming from the diagonal. There is not much disease distal to the carina, but there is some plaque proximal to the carina in the main vessel. And we can identify the best proximal landing. This is the different pictures from distal to proximal. And the plaque is mostly accumulated in the polygon of confluence or in the just proximal to the carina. Then the strategy in this case is clear. We have to go for a crossover stenting. This is what we did. Balloon to diagonal, DS in LED diagonal, pot 3 millimeters in the LED, balloon to LED, and something that is empirical, I like to do it, but this to apply a DCB to the vessel, not very aggressive because it's not an stenotic vessel. I don't want to create any dissection. It's just to prevent any reaction in the innocent main vessel in this case. Then they apply DCBs in these cases, but I am not aggressive. Finally, we have the result. We have the intention of doing just without kissing. This is the result, not good. The stent is just like a half moon, you can see in the right. And then after kissing, the result is good in this case. This is very important sometimes even in provisional results, in only one single stent, but it's very clear. This is the final result of this case. We have another example of the classic 001 diagonal stenosis that was treated with the DES from LED, from diagonal to LED to 25, according to the distal landing site in the diagonal, then pot with 3 in LED, and rewiring, stress opening, and IBUS, in this case with score registration, and it's really clearly, we can identify suboptimal results that are not evident in angiography. In this case, we have a malapposition, a gross malapposition in the proximal, in the main vessel of the stent that was fixed with a larger balloon pot, and then we have a good apposition, as you can see in the still image down. This is another example of a case that have some particular features because there was a previous stent implanted in LAD by an operator that he tried to adjust to the ostium, but we do not know now if this circumflex that is really disease in the ostium is jail or not. Then we have two questions to answer here. First, the wire is going just that way, which is correct because the stent is properly nailed to the osteum, or maybe we are just crossing the cells of the stent going to the cert. And the second question is if there is plaque or not extending to the left main. That's the reason why we did IBUS in this case. First from LAD, this is the old stent without significant restenosis, and you see the left main with some plaque. And now from the circumflex, when we see the distal normal reference, the tight lesion here, and the wire coming from LAD, and having this range analyzed immediately, we have a clear idea that the stent is really adjusted to the osteum. Fortunately, the wire is not crossing the cells, and there is plaque in the left main. So the strategy in this case is crossover stenting from left main to circumflex, is what we did, with 3.5, pot with 4.5, and then stratus opening, and again the DCB to LAD is what I cannot give you any evidence, but they like to do that. And finally, the kissing, and we have a final IBUS with a very good result, which is a polygon confluence, when you see perfectly a huge lumen and the two stents now. Of course, these are IBUS cases, but OCT may provide more fancy images and more effective images when you are trying to evaluate, for example, the floating stents or the presence of a stretch over the main vessel. As an example of floating stent, and the operator crossing with a wire perform a mini culotte. That's to correct for this abnormality, to just illustrate and to show how OCT can be more illustrative in these cases. What about the evidence for use of imaging in this 001? We don't have any evidence. In the October trial, the dedicated trial for bifurcation, 001 was excluded specifically. There is no evidence coming from this trial. And I think, well, I was unable to find really important stuff, but I found this with this an IBUS study, it's a registry, and they, by propensity score, were able to make some analysis. They included 233 osteal lesions, 50-50 between aorto-osteal and other locations osteal lesions. And they found these positive hazard ratios for use of imaging, with reduction on MACE, TLR, MI, and very close to signification reduction on TLR. And these hazard ratios were equivalent for the half of lesions that were aorto-osteal and the other half that were other osteal lesions. So this is not a randomization, this is not a randomized trial, but some insects, they provide some positive news about the use of imaging. No? In summary, I think the Medina classification is based on angiographic, and this is valid, it's true, but intravascular imaging is helpful to redefine the pattern of the disease in these lesions. This is particularly relevant in 001 because the definition of the disease pattern may have important implications with regard to the optimal management approach, and also helps to optimize results and identify pitfalls that could decrease these really pretty high MACE rates that were presented, for example, over 13%, 14%. A clinician would say, why are you treating these lesions? You have more MACE than the problems that to leave the lesion behind with medical treatment could be associated. Then we have, as interventionalists, be very careful with this. So my answer to the question is that does image change our therapeutic strategy? It could be, I don't know if it changed for you, but it should. And I think that's the conclusion that I can give you. Thank you.
Well, that was a beautiful talk as well. I personally, as a visual person, I loved your diagrams because they really illustrated some of the challenges that we try to sort of figure out. And it also complements beautifully the prior talks. So thank you for that great presentation. Any questions from the audience or the panelists? We are kind of chewing a little bit into our lunchtime. And yeah, go ahead.
Just a quick one, fantastic talk. What do you think about stent design in terms of 2-connector, 3-connector for this type of lesion? Do you think it has a difference, and also the platform stent to artery ratio?
I think one of the issues concerning the treatment on osteal lesions, more aorto-osteal than these osteal lesions, but as well, is maybe, but we need platforms that have radial force. These lesions have recoil, and it's not uncommon to implant the stent. You see the full expansion of the balloon. You remove the balloon, then you do imaging, and you see the osteal with some expansion, small lumen. You post-dilate again. Even with larger balloon, the balloon is going up, You remove the balloon and the lumen is going down again. Then I think my favorite platform for these lesions should be one with more radial force. The problem is that the trendy thing is to have very, very thin struts, 60. Even maybe in the future we have 40. It's very nice to navigate, but it's not so good for osteal lesions. And the second is if we are going to do a crossover, a provisional, inverted provisional, we need, and there is a disproportion between the side branch and the main vessel, the platforms that are appropriate for overstretching and don't have the risks of shortening or just breaking. And when you do this from 2.5 maybe to 4, then you need to know very well what platform is more suitable for these overstretchings at the same time.
Regarding the type of intracoronary image, do you prefer the IBUS to the OCT or
I think both are useful. The only thing is that you need to know what is the plaque burden in the main vessel. That's true. Usually the disease in the main vessel in the true angiographic 001 is not very big because otherwise it's not a 001. You would say it's a 101 or whatever. But I think that both can be used. For the planning initially, maybe I prefer IBUS because I see the whole plaque burden, the whole vessel size. But for example, when the stent is implanted, OCT is better in order to show where are the struts and what's the malposition or whatever. Then every technique has different shortcomings and different advantages, but I think you can use both in these osteal lesions.
I have a technical question. If we put the stent main vessel to the left main to circumflex, then usually the stent malposition occurs in the POC area inevitably. Do you recommend the mandatory final kissing balloon dilatation?
Yeah, I think so. Yeah, we did in this case. I think you're right because the stent coming from the left main to the third has some malposition just in the puck. Then you need to sheet off the stent at that level and with the previous dilatation to the LAD in this case, and then final kissing is going to be mandatory to have a reasonable result. Yeah.
Okay. Thank you so much. Fabulous talk. Okay, so as they say, what stands between you and your lunch is my good friend Fernando Alfonso, who has been a leader in the field as well, and he's going to talk to us about 001 restenosis after 1 and 2 stents for bifurcations. Fernando, welcome.
Okay, so thank you very much for this kind invitation from the board, and especially to Manolo, that I was on vacation, I received the invitation, I was very pleased. So basically, it's quite easy. There is plenty of information, as you may see there, on the treatment of ISR, randomized clinical trials, consensus, and clinical practice guidelines. And there is also plenty of information on how to treat bifurcation. And the work of this group is being of major value in this regard. However, unfortunately, in most trials, assessing the value of different strategies for ISR, bifurcations are systematically excluded. In the same terms, in patients with dealing with how to treat bifurcations, ISR are excluded. So there is very limited information on how to treat ISR after drug-eluting stent information. And if we just concentrate in the 001, well, virtually it's not data. And this is why I was not so happy when I was trying to prepare the talk. So that what I will do is just present a general overview of the information available, and hopefully this won't be too disappointed. So we know from the 2018 revascularization guidelines that both drug-coating balloons and drug-eluting stent may be used, and this is a 1A recommendation for patients with stent restenosis. And also, in those guidelines, we emphasize that intracoronary imaging was of value. We put together, this is a paper led by Andan Castrati. This meta-analysis is a patient-level meta-analysis with 10 randomized clinical trials with nearly 2,000 patients. And you see here how, when we compare drug-eluting stents with drug-coating balloon, there is a benefit regarding target lesion revascularization with the use of drug-eluting stents. But this is a major interaction here. So the benefit is when we use in patients with drug-eluting stent restenosis, but there is no clear benefit in patients with a more favorable setting of bare metal stent restenosis. Regarding safety, there is this signal, there is a concern of a worse outcome for patients treated with a stent. As you may see here, not significant, but again, the signal concentrates when first-generation drug-eluting stents were used, and there is no signal of any concern whatsoever when second-generation drug-eluting stents were used. Now, if you review all the current randomized clinical trials in stent restenosis, you may see in light blue that recently drug-coating balloons are selected for most of these trials. And when we review the evidence, I think it's important to emphasize that every time we face a patient with ISR, it's important to make a good diagnosis, to define the lesion. It is very important to prepare the lesion before a final strategy that can be drug-eluting stent or bare metal stent. So until now, we were saying, well, DCBs should be preferred when there is multiple metal layers, when there is resistant under expansion, when the initial result with pedalation is excellent, high bleeding risk patients, perhaps for many operators, first in stent restenosis, and also, as mentioned, patients with bare metal in stent restenosis. But there is very weak evidence. I mean, there is quite a consensus that when the ISR is involving a major or significant side branch, drug-coating balloons are better. Now, the problem is that in the new guidelines of chronic coronary syndrome, the presentation of the two strategies are very different, as you already know. So in these guidelines, it is said that in patients with in stent restenosis, this should be preferred over drug-coating balloon with a 1A recommendation. So perhaps we can discuss this at the end because it's quite controversial. Now, the other issue is that this group made this proposal suggesting that the Medina classification in de novo lesion can also be used nicely for patients with ISR. This is important. And this is an editorial we wrote some years ago with Manolo, very simply explaining why, the nailing technique, trying to catch the ostium of the side branch, can be virtually impossible. And sometimes, there is major protrusion of the stent in red to the main vessel. This problem is more complicated in patients with one stent in the main vessel, and is, too complicated perhaps when we got two stents because it's, metal everywhere, and perhaps we need to avoid this strategy. Now, the other side of the same story is what we know about bifurcation. I mean, you are experts here in the field. This is a meta-analysis we performed some years ago regarding the DCBs for de novo lesions, and obviously in selected patients where the two strategies were considered of value, we found that the primary endpoint of this meta-analysis, TLR, was similar for DCBs as compared with other strategies, and this applies for patients that were included in bifurcation randomized clinical trials. So regarding other meta-analysis, this is a very nice meta-analysis by the group of Simon Ecclestad, putting together both randomized clinical trials but also observational studies. And you may see here that there are, very heterogeneous kind of treatment, but eventually the meta-analysis could demonstrate that DCBs were superior for POVA for the treatment of side branches. And this is the data coming from this meta-analysis. There is another meta-analysis, again, randomized clinical trials, but also observational data, and basically the same results. At angiographic follow-up, DCBs in the side branch are superior to POVA in the side branch. But we may know that. So regarding the question of ISR after the therapy of a bifurcation with a stent, this is a study, a classical study by the group of Antonio Colombo, and you may see here they compare drug-coating balloons versus second-generation drug-eluting stent for the treatment of restenosis lesions involving coronary bifurcation. As you may see in red, only a minority of these ISR were actually 001, and the conclusion of the study was basically that the two strategies, a stent strategy versus a DCB strategy, were similar, but in this paper it was emphasized that the initial stent-in-stent strategy was associated with MACE. And this is another patient, again, related to the topic. This is angiographic clinical outcome of patients treated with DCBs for in stent restenosis, a coronary bifurcation, stenting with 2 stent strategies. So in this paper, coming from the group of Robert Byrne, you may see how they perform a very detailed QC analysis of the branches. A follow-up, the side branch was showing the major impingement, the major involvement regarding minimal lumen diameter and percent diameter stenosis. And again here, a small number, but perhaps larger, up to 40%, were 001 bifurcation. This study compared 2 DCBs, and eventually the results suggest that the 2 DCBs were similar to address these challenging patients. But during follow-up, 1 out of 4 of these patients suffer recurrent in stent restenosis, and this was mainly involved the side branch, so emphasizing the importance of obtaining a nice result. Again, going to the guidelines, we recognize that OCT or IBUS is of major value. Every time we're facing a patient with stent failure, either stent thrombosis or ISR, and as mentioned by Chema, the October trial suggested that coronary imaging can be of major value in bifurcation, even though the 001 that we are dealing today were excluded from this trial. And we note also that this is a classical study suggesting that physiology is mandatory for this lesion, because when we face these patients, sometimes not only at initial presentation, but as you may see here, also at follow-up, when we do a follow-up angiography, and you see this narrowing in the ostial of the side branch, then the FFR in most cases is negative. So obviously we need to avoid that. And regarding the election of the DCB, well, this is data that we published quite recently. Limited studies, but 6 randomized clinical trials comparing DCBs with paclitaxel as compared with Limus DCB, at least the current generation of Limus DCBs. And it is very clear that late lumen loss and late lumen enlargement is much better when we use paclitaxel DCBs. So to summarize, I think it's important when we address ISR presenting with a Medina 001 pattern, that clinical indication is revised, symptoms, ischemic relevance of the territory. I think it's very important, and we sometimes forget to revise with care how the initial procedure was performed, the technical details, as sometimes this is giving some clues. I think it's important to ensure that the side branch lesion is causing the symptoms of the patients. And if the side branch is not very small, I think imaging can be of major value. So my personal bias is that for these lesions, DCB with paclitaxel drug is the strategy of choice. I think it's important always to protect the main branch, and it's important to prepare the lesion and try to optimize the final results. So thank you very much.
Thank you very much for this great presentation. Just one question. It wasn't said today. What about bioresorbable scaffold? Of course, new generation. Might be this device could solve the problem of 001. What is your opinion?
So BBS?
Yeah, but there's a new generation without this bias of past.
Well, we performed some studies in the Reeves saga with BBS in conventional ISR. Very good initial results, but when we compare our data, and we now presented this in JAC interventions, the 3-year follow-up of ISR treated with BBS, the absorbed one, with DCBs, paclitaxel, or everolimus eluting stent, there is a price to pay in the treatment of these patients that is more clear when the analysis, you perform a landmark analysis after 1 year. So the same information we got for the general BBS also applies for patients when this device is used in stent restenosis, which is very appealing because you don't need another scaffold. Regarding the new scaffolds, I think we don't have any data, but again, this is very attractive.
Thank you very much. So we have still 1 minute for last burning question. If not, so...
Regarding the restenosis coming from one stent, 001, but with a previous stent at the main vessel, what do you prefer, to complete a two-stent procedure, T-tap or culotte, or apply DCB?
I would try to avoid using stents and as much as possible.
So now, just to conclude the very interesting session, Manuel Pan will show us some, let's say, directions of new investigations.
Thank you.
Do we need randomized trials or not?
Yes. Yes, definitively yes. Regarding this type of lesion, has been previously mentioned, we need a Medina reclassification, Medina physiology and Medina IBUS or OCT. Sometimes if you use physiology, you reclassify the lesion, as previously mentioned, from 001 to 000, so you don't need to treat it. This is the first approach. And then, has been also previously by Chema exposed brilliantly, that the use or IBUS or OCT again reclassify the type of Medina. So this finding is important in order to establish the therapeutic strategy. Regarding the treatment of the 001 Medina lesion, we have few evidence. That this is the sense of the EBC, to discuss problem of bifurcation lesion with few evidence and obtain a consensus or not. In this slide, you can see the different scenario. On the left, the 001 lesion with a small lesion, a small side branch, so it's easy to decide. It's a medical treatment. Again, if the side branch have a negative physiology, medical treatment. In the middle, the side branch is significant, close to the main vessel or a little bit smaller. And here you have different possible strategies. The use of DCB with a good preparation of the plaque, inverted provisional, or nailing the ostium, as Soledad mentioned, in the left main when the angle is favorable. When the side branch is equal to the main vessel, you can use the inverted provisional stenting and change the mother for the daughter. So treat the lesion as a 0-1-0. And finally, regarding the Medina 001 in the setting of a restenosis, if the restenosis comes from a simple approach, you can complete the complex approach with two stents, with T-tap or culotte, or as Fernando mentioned, use again the DCB. If the restenosis comes from a two-stent approach, you have to use image, correct deformation, and the dark coating balloon seems to be reasonable instead of a new layer of metal. So this is we have not evidence, we need a randomized study, and I think that these two studies may be proposed for members from the EBC. I think the most popular strategy are the inverted versus the use of DCB. This is maybe a randomized trial, and also at the level of the left main, the use of nailing versus crossover maybe another proposal when the anatomy is favorable. Thank you for your attention. We need a photo of the meeting. Goran.
Yeah, dear friends, it's tradition to take group photo. We will do it now before the lunch, so please stay together. I don't know the place, but there is Ben, and he will take the photo. So let's make photo, and then we go for lunch.